Good morning, everybody. It's a great pleasure to be back here with you doing a live feed. Just before we start on a topic which is extremely important, entitled Endometriosis and Infertility, the relationship and how we treat it, and the basis for such treatment, let me again invite everyone watching this live feed to call me or call my office or call my assistant, Patty, and set up a consultation with me for an online consultation to discuss your particular issues. You can access us by calling 702-533-2691, 702-533-2691, and asking Patty directly to set you up with the online consultation. Or you can go to my website, sherivf.com, just plain sherivf.com. When you get to the home page, you'll find an invitation to book a consultation with me. Just follow the information there, click on the appropriate sites, and it'll take you to a form that you can fill in. Fill it in with all the details requested, and then submit it, and we will reach out to you once we receive it to set up the consultation. Important to give us your personal cell phone number as well, because that cell phone number will help us reach you more easily. Now, the other way to reach us is to email Patty directly at sher@sherivf.com, sher@sherivf.com. Patty will get back to you if you give her your cell phone number, and after all of these endeavors, you will receive a questionnaire. This is very important to fill in with as much detail as possible. The questionnaire will be returned to us, and if need be, Patty will help you complete that questionnaire. And upon receipt, we'll set you up for the consultation. It's really important to do that as soon as possible, because I'm very inundated as the number of people calling in for such consultations is growing exponentially. Okay, so now onto the topic at hand, endometriosis and infertility. Let me first explain what endometriosis is. It is a condition where the lining of the uterus, instead of being menstruated during menstruation, also passes back, we believe, through the fallopian tubes to reach the pelvis. Now, the fallopian tubes are at the ends of the top of the uterus, and the ends hang over the ovaries like shower heads. And when the woman menstruates, she bleeds not only outwardly, as we know most menstrual blood passes, vaginally, but also goes backwards or retrograde through the tubes, so some of the blood spills out through the ends of the fallopian tubes or the fimbrial ends into the pelvis. This blood contains live cells from the endometrium, and these cells love to grow on the surface of the peritoneal membrane. And they grow there, and under the effect of estrogen in the first 2 weeks of the cycle, they proliferate in clusters or little islets all over the pelvis. And the cells multiply until such point that the woman ovulates or receives the hormone progesterone by injection. And that progesterone signals the woman's immune system, the janitorial cells of the pelvis, to rush to the pelvis and go through the little pores in the peritoneum and get into the pelvic cavity, where they are believed to engulf, like little Pac-Men, all these little deposits in the pelvis and clear the pelvis completely, so that by the time the next period comes along, the pelvis is clean. And this happens in most women. Most women who have at least one open fallopian tube will menstruate in both directions, mainly outwards to the vagina, but also through the fallopian tubes and their ends into the pelvis. Now, it is important to understand that in some women, and I will try to give you a profile of this type of woman in a few moments, some women, the clearance of these deposits, the immunologic clearance of these deposits by the macrophages, lymphocytes, and monocytes of the immune system that reach the pelvis every month, doesn't occur completely, so that some of the cells remain and some of the deposits are not cleared, and these deposits of endometrial clusters all over the pelvis occur in all women, and there are many, many of them, and these occur, as I said, every month. Now, in some women, this is an incomplete process. And now, month after month, year after year, decade after decade, this builds up until eventually there's so much endometrial tissue that when the woman menstruates, she bleeds into these clusters of tissue as well. The blood is then absorbed after the period ends, and in these cases, the iron pigment present in the red stuff within blood called hemoglobin, the iron pigment known as hemosiderin, remains behind as a telltale sign that there was excessive bleeding, or that there was bleeding into these deposits, into these clusters. And so now when it absorbs, the pigment remains behind, and then when you go into the pelvis and you pass a little telescope through the belly button into the pelvic cavity and look around, you will see these little deposits with their pigment of hemosiderin, that iron pigment all over, and it looks like what we often refer to as gunpowder burns or pigeon eyes that you see. That's simply the iron pigment. Now, these little clusters can eventually become confluent. They can merge with one another and form larger areas of endometriotic deposits. And when this happens, then the lubricating effect of the secretions in the pelvis that prevents pelvic organs from attaching to one another, because all pelvic organs are covered by this membrane, with secretions coming through the pores in the membrane, then what happens is that the membrane then sticks to pelvic organs and to itself, to surfaces, like inverted Scotch tape. And these adhesions then add to the problem of normal free movement of pelvic organs and contribute to the infertility. And in other women, what happens is that the deposits on the ovary now merge together, and when the woman menstruates, more and more blood collects in the deposits, till eventually it becomes like a little cyst, a little loculation of fluid that grows and grows. Frankly, I've seen them as large as footballs. And these are called endometriomas because they contain decomposed blood, menstrual blood, which looks like chocolate when it's melted. So we call them chocolate cysts or endometriomas. These cysts themselves can rupture, spreading this throughout the pelvis. I've seen them of numerous sizes. I once had a woman that I was called to see in the emergency room with a belly full of fluid, and it was a large endometrioma the size of a football that had literally ruptured in her pelvis and caused an acute abdominal crisis. She had to be operated on and lost that ovary. But the important point to know is that endometriosis can be very mild, where there are just a few little deposits noted in the pelvis with these pigeon eyes or gunpowder burns. That's early endometriosis, stage 1. In other cases, it can spread and it can become confluent and cause some adhesions in the pelvis around the tubes, on the exterior surface of the fallopian tubes, and around pelvic organs. And this is stage 2. In other cases, it can spread and become more extensive with endometriomas, and then stage 3 or 4 or more advanced endometriosis. Obviously, the more advanced the endometriosis, the more the anatomical distortion. Therefore, the more likely it is that the tubes will be damaged. The more likely it is that the tubes won't be able to apply themselves to the ovaries and pick up the egg in the process of ovulation. And so the more advanced endometriosis are more likely to cause anatomical abnormalities in the pelvis that contribute to infertility. But the problem with endometriosis is that even the mildest form of endometriosis is associated with infertility. And let me explain to you why. The secretions, these deposits in the pelvis, even in the early stages, stage 1 or stage 2 endometriosis, release toxins into the secretions of the pelvis. These toxins aren't very well defined, But what they do is that when the egg leaves the ovary to cross over into the fallopian tube to fertilize the sperm lower down in the tube in order to cause procreation to occur, this particular egg has to pass through the secretions in the pelvis where these toxins are present. And this is like trying to swim across a river full of piranha fish or full of alligators. You may dive in at the one end quite healthy, but it's not likely that you'll get to the other bank. Even if you do, you're not going to be in a position to make a journey from there onwards. So it is that the egg leaving the ovary, passing through these secretions, leaves the ovary usually in a completely healthy, normal state. But by the time it gets to the tube where the sperm is, it's been affected by the toxins in the secretions. Now, the egg in the human is no different than a chicken egg. It has an envelopment around it called the zona pellucida, the shell of the egg. In the human, of course, it's much softer. This shell has little receptors on its surface through which the sperm must attach and then pass through to get into the egg to fertilize it. And what happens is that these toxins compromise this reaction in the receptors. So the net effect is that the egg can't easily enter the sperm can't easily enter the cell. Again, the egg was normal when it left the ovary, but by the time it gets into the secretions and then from there passes into the fallopian tube for fertilization, the sperm can't easily fertilize it. In fact, it's believed that the chance of fertilization could be up to 6 times lower than ordinarily would be the case. Now think of this. If a woman in her early 30s or late 20s would have a 20% chance of getting pregnant per month on her own if she were fertile, and maybe an 80% chance per year of trying, now because of this compromised ability where the egg can no longer be easily fertilized, it's going to be about 2 or 3% per month and 30 to 40% within 4 to 5 years. So in fact, what the endometriosis does in the mild cases, it doesn't render the woman sterile necessarily or infertile completely, but it reduces her chance of getting pregnant per month of trying, to the extent that as she gets older and egg quality declines with time, her ability to get pregnant, her ability to have a baby is further compromised by the biological clock. For this reason, endometriosis is devastating, especially for women who get older and go beyond the age of 35, when egg quality is affected by the clock and through wear and tear of eggs that have been in the woman's ovaries all her life before she was born. So being there before she was born. So for this reason, endometriosis is a common cause of infertility. In fact, 10 to 15% of all women between the age, 10 to 15% of women of reproductive age will have endometriosis, and 60 to 70% of women who present with pelvic pain that is chronic in nature will have this condition. So endometriosis is a debilitating disease. If it becomes advanced, it causes more symptoms, but it is a disease of infertility from its very earliest stage because of its reduction in the woman's potential to conceive per month, something we call fecundity. Her fecundity is reduced up to 6-fold. And of course, the more advanced the endometriosis becomes, the more scarring and adhesions in the pelvis will compromise the flow of the passage of the egg to the sperm. And the more it involves the ovaries, the more it can extend further. One other problem is that women who have endometriomas in their ovaries, these chocolate cysts, the ovary also gets affected by the cyst that is formed there, causing a reaction in the ovary, which we often refer to as a misfit tumor, which causes the ovary to produce more male hormones. And if there's excessive production of male hormones by the ovarian tissue, it will interfere with egg development in the ovary and compromise egg quality. That is why I tell women who've got endometriomas any more than 1 centimeter in size to have these endometriomas dealt with, and we'll talk about this later, before doing a transfer of embryos to their uterus, or the chances, before undergoing egg retrieval, or the chances of getting healthy eggs that are competent to make good embryos will be reduced by this effect of overproduction of ovarian male hormone, predominantly testosterone. So that's the story with endometriosis and how it develops. So the mechanisms for reduced fertility in women with endometriosis is simply the presence of these lesions. Even before they expand and extend and cause scarring in the pelvis, it is aggravated by scarring that binds the tubes down or even blocks them in very severe cases. And it's made worse by the endometriomas that can form in the more advanced cases, which in themselves can spread the condition by rupturing or can compromise egg development in those ovaries. But there's one other very important mechanism that needs to be considered, and that mechanism is an immunologic mechanism. Back in the early 90s, we were among the first people to show that about 60% of women with endometriosis have antibodies in their blood called antiphospholipid antibodies. These antibodies can interfere with the development of the root system of the embryo when it tries to grow in the uterus by destroying the surface cells in the root system and preventing the embryos from attaching. This can happen, but the bigger problem with endometriosis and immunology is due to the presence of what we refer to as natural killer cells. These natural killer cells are present in the uterine linings of all women. You've got to have them. If you don't have natural killer cells, you won't be able to develop a placenta. The root system of the embryo won't be able to grow into the wall of the uterus and form this placenta, which is the lifeline for the baby. Normally, endometriosis produces growth factors that attract the roots of the embryo into the wall of the uterus so that the placenta can form. One form of these cytokines is called Th1 cytokines. It balances the other cytokine known as Th2 cytokines. The Th2 cytokines attract the roots into the wall. The Th1 cytokines prune down the roots, or they trim them, so that the placenta will form on the inner aspect of the uterus, and when the baby is born, it will come out easily after delivery of the baby. Now, you've got to have a balance between Th1 and Th2 cytokines for there to be an orderly development of implantation and the placenta. If you don't, and you have an excess production in the Th1 cytokines, it will kill the roots of the embryo, destroy the cells of the roots so early that the woman will usually not even know that she was pregnant in the first place. She'll think she's not getting pregnant, where what's really happening is she's having a mini miscarriage so early she never knew she was pregnant. So such women often present to us with so-called infertility without realizing that what's really happening is that they're losing the pregnancy every time it starts. So here's the problem. Women who've got early endometriosis with no other problem whatsoever have reduced fecundity because of the toxic environmental effect caused by the infertility, by the deposits. And such women will usually not be diagnosable except for symptoms they often present with. The symptoms are painful periods. The second symptom is pain with intercourse that is positional with deep penetration, usually a few days before the period comes. And the third one is that the woman will have pain with ovulation. When the woman ovulates, usually it's completely painless, but it can be painful with endometriosis because of the fact that there's congestion in the pelvis, and the release of the egg often irritates the deposits in the pelvis, causing local pain. So when a woman presents with painful periods, pain with ovulation, and pain with intercourse that is positional with deep penetration, and she's in the reproductive age we usually think of endometriosis as the top of the list. And I want you to know that there's another test that you can use, a newer test that's come out called the Reproductive test. This test does not make an absolute diagnosis of endometriosis, but by doing a blood test, you can tell whether there is a hint or suggestion of the condition existing. It's worth doing in some cases, but frankly, it can be wrong. It's not that reliable, in my opinion. So, if you suspect endometriosis in a woman who's having infertility and has these painful and has these symptoms that I've referred to, heavy bleeding, pain with intercourse, and pain with ovulation, the only way to absolutely make a definitive diagnosis in the early stage of the condition is to do a laparoscopy that I referred to above. Now, you need to understand that doing the laparoscopy will help you make a diagnosis, but it may not be of any benefit whatsoever in treating the condition or the infertility associated with it. Why not? Because bear in mind, for every deposit of endometriosis that's in the pelvis, there are others coming up at the same time. It is an ongoing condition. It doesn't end by going in there and doing a laparoscopy, diagnosing it, and ablating through laser or heat or fulguration these deposits. Because again, for every deposit you see, there are probably a whole batch of others coming up. So you cannot get rid of endometriosis. It is an ongoing condition that only disappears once a woman stops having periods completely and gets beyond the menopause, by which time the infertility, of course, is irrelevant. So bearing this in mind, you can understand that if you give a woman fertility drugs to make her ovulate and release more eggs, if you do surgery to get rid of the lesions that you can see by lasering them through laparoscopy or ablating them, if you do intrauterine insemination, which is a procedure that I introduced into the field of medicine in 1984, which kind of dates me, but so what? The point is that if you do any of those conditions, you're not solving the problem. The chance of success, the chance of such treatment, getting the woman pregnant, is no greater than no treatment at all in women with early endometriosis. It's no better than no treatment because you can't see the lesions that are not visible. In the early stages, these lesions are translucent. You will not see them until bleeding occurs and a pigment appears in it. So you will not get rid of all the lesions by doing the surgery, and you will not be able to get away with giving fertility drugs to make a woman ovulate because you're not getting rid of the toxins that are present in the pelvic cavity even before the lesions are visible laparoscopically. And for that reason, when you do surgery or you do intrauterine insemination or you give fertility treatment or all of those, you have no greater success than no treatment at all, especially in women with early endometriosis stage 1 and 2. Now, obviously, if you get rid of a lot of adhesions and you get rid of the endometriomas that are present there, you remove those hazards. But it will not help the woman getting pregnant to do surgery in the early stages. The only treatment that will improve the chances of success is to do in vitro fertilization. Because with IVF, you remove the eggs before they're released into the toxic pelvic environment and get compromised. And then you fertilize them outside the body and put them in the uterus. You lock them up in the uterus, and therefore the woman will have a better chance of getting pregnant, provided that she does not have an immunologic problem linked to activation of natural killer cells, their toxicity, where they overproduce Th1 cytokines, and there are not excessive antiphospholipid antibodies present. And we'll get to that in a few moments from now. Simply stated, endometriosis in young women, because it usually doesn't cause sterility, can be treated if the woman's ovulating normally, taking an expectant approach. If the woman's willing to wait, try on her own, have timed intercourse based upon tests that show when ovulation is occurring, she might still get pregnant. But instead of a chance of getting pregnant being 20% a month, it's going to be 2 to 3%. And instead of a chance of having a baby within 1 year being 70 to 80%, it's going to be 40% within 4 to 5 years. And for this reason, the woman getting older, as her egg quality is declining because of wear and tear of eggs through the advancing biological clock, cannot often afford to wait and waste that time as her egg quality declines. And very often in the older woman, she starts to run out of eggs and she's developing diminished ovarian reserve, as evidenced by falling levels of AMH in her blood. When the level of AMH drops below 1.5, time is really nanograms per milliliter, or perhaps 10 picomoles per liter if you live outside the United States, then your chances of getting pregnant are going to be reduced because you've got fewer eggs available at IVF and your time is running out. So for a woman of any age with diminishing ovarian reserve, with falling AMHs, and any woman over 35, you need to be serious about getting this thing dealt with before it's too late and make hay while the sun shines, meaning that IVF becomes by far the best treatment to use. Intrauterine insemination, as I said, surgery or fertility drugs, or all three, will do no better than doing nothing. You're far better off going to do something that will have a definitive success. For women that are younger, however, if you want to take the risk and wait, if you don't have diminished ovarian reserve and you're in your early 30s or late 20s, then certainly you can wait. But you've got to understand that by doing so, you may get pregnant. But it will not be due to wait. It will not be due to any treatment you take other than IVF, not due to simply waiting. It will be in spite of what you're doing. So your chances using fertility drugs such as clomiphene, letrozole, or injectable fertility drugs, with or without IUI, are not really going to improve your chances. You're simply hoping for a miracle to occur, which will occur in many cases. And remember again that because endometriosis can produce a pregnancy, even when it's present, there can be a pregnancy. It's one of the common causes of women being able to get pregnant once, have a baby, and then not being able to get pregnant easily thereafter. It's a common cause, in fact, the commonest cause of so-called secondary infertility. Unfortunately, very often, these women who do get pregnant when the doctor has given them fertility drugs, and they got pregnant in spite of this treatment, not due to it. But they erroneously believe, and obviously the doctor also does it often in many cases, that it was the treatment that got them pregnant, when in fact they got pregnant in spite of it. And so they go back and try the same treatment over again, and it doesn't work. And they continue to lose time at a time when they don't have time to waste. So clearly, IVF is the definitive treatment of choice for any woman who wants to get on with it, because it's the only thing that's going to improve her chances. But it is definitely and definitively the treatment she should move towards if she's getting older or if she's got diminishing ovarian reserve. These are important considerations. Now, a few words about the immunologic cause. IVF is also, in my opinion, the only rational treatment if the woman's got activated natural killer cells, which need very selective immunotherapy. About 15 years or longer ago, we used to use a substance called IVIG, or gamma globulin, intravenous gamma globulin, which we infused intravenously into the woman's veins, along with steroids, and the IVIG would regulate the natural killer cell concentration and the presence in the uterus, and it would basically improve the chance of getting pregnant by removing the problem completely. But IVIG is extremely expensive. One shot of IVIG, and certainly 2 shots, can be as much as the IVF alone, and you would require 2 intravenous infusions or shots. One 10 to 14 days before the embryo reaches the uterus, and another intravenous infusion after the pregnancy test is positive, and this combined with dexamethasone or prednisone or prednisolone steroid therapy. I prefer dexamethasone, 0.75 milligrams daily. So the IVIG works, but it's extremely expensive and it has a lot of side effects. It can in fact even be dangerous. Some women can have an allergic anaphylactic reaction to IVIG, especially women who are low in the gamma globulin in their blood known as IgA. So women with low IgA levels are really not candidates for receiving IVIG anyway. But the good news here is that we no longer need IVIG. Early in the century, around 2003, 2004, one of the researchers in our center was able to identify that the use of an innocuous substance known as intralipid, which is not a blood product, which IVIG is, another good reason why you don't want it. Intralipid is just as effective as IVIG, and it costs 25 to 30 times less. It's infused 10 to 14 days, but not sooner than 10 days before the embryo transfer. 10 to 14 days before the embryos are transferred, it is infused in a 20% solution slowly over 3 or 4 hours into the woman's blood. And then this is combined with dexamethasone, 0.75 milligrams daily. The intralipid is, as I say, much less expensive. It is a synthetic substance, so it's not a blood product, and this is something, therefore, that isn't as frightening in this day of HIV and hepatitis B that can be transmitted by blood. And it is highly effective. Side effects are minimal except for women that tend to be allergic to chicken eggs. So for that reason, intralipid has all but supplanted the use of IVIG. We do thousands and thousands of such infusions. I have a woman that had a baby with us after having failed 23 IVF attempts with natural killer cell activation through appropriate treatment. And that woman, I think, she was 42 when she got pregnant, and in fact she was even premenopausal. So it works, and it's very effective, and we have treated thousands and thousands of women, and thousands of babies have been born through such treatment. In fact, my practice is very heavily tilted towards women with immunologic causes of implantation dysfunction that we refer to as immunologic implantation dysfunction, or IID, and very successfully so. They come from more than 45 countries to see me, and we've been blessed by being able to help many, many of them have babies. Now, this type of natural killer cell activation is only one of several types. It is the one that occurs with endometriosis. It can be eliminated through appropriate immunotherapy of intralipid and steroids, and you don't need more than 2 infusions. And the dexamethasone is stopped slowly by the time the woman gets near the 10th week of pregnancy to prevent any adverse effects on the baby. So this is the treatment we do with intralipid, and it's highly successful in women with endometriosis. Again, a caution. If a woman is over 35 years of age, if she's got natural killer cell activation or antiphospholipid antibodies as an IID causing failure to conceive, or if she has got has got diminished ovarian reserve, or if there's any evidence of any of these situations, IVF becomes the treatment of choice for any such woman and women over the age of 35 years. For all other women, it becomes a choice for those that are younger. They can go without treatment and wait to see if they conceive, provided they don't have activated natural killer cells and an IID, or they can decide not to waste time and to proceed directly to IVF. Very important to understand this scenario because, as I said, endometriosis is a very common cause of repeated and often unexplained IVF failure through any of the mechanisms I've mentioned, very commonly because people don't recognize that if the disease is only minor, stage 1 or stage 2, it still doesn't mean you can cure it surgically or medically. You need to proceed with a definitive treatment in the form of IVF to get an improvement in outcome. I hope this is helpful to you and you'll have a better understanding of what endometriosis involves. And if you've got endometriosis with repeated IVF failure or unexplained infertility that subsequently is explained by laparoscopy or suspected through symptoms and or the receptiva test, I think we should talk. So please contact Paddy or go to my website or email us and set up an online consultation and a discussion on how we might proceed.